The last item related to the brain that we will discuss is the cranial nerves. These are nerves that leave the brain. They are part of the peripheral nervous system, but because they are attached to the brain, we're going to discuss them here. There are 12 pairs of cranial nerves, so a right and a left for each pair. They all arise from the brain. Some arise from different parts of the brain, however. They exit the brain through foramina or foramen, leading to muscles, glands, and sense organs in the head, neck, and torso. So if you were wondering what the hypoglossal canal was for, it's for the hypoglossal nerve. So we have many holes in the skull where these cranial nerves exit. The input and output are ipsilateral. Ipsilateral means on the same side of the body, except cranial nerve 2 and cranial nerve 4. Those two cranial nerves have contralateral input and output. Our first cranial nerve is the olfactory nerve. This olfactory nerve is at the base of the frontal lobe, and the filaments of the olfactory nerve reach through the cribriform plate into the nasal cavity to detect smell. The olfactory nerve is responsible for your sense of smell, and if it is damaged, it causes an impaired sense of smell. The olfactory nerve is a purely sensory nerve. The optic nerve provides vision. Damage to the optic nerve causes blindness in the visual field. The optic nerve is one of the nerves that has contralateral input and output. What that means is that the information from the right eye goes to the left brain, and the information from the left eye goes to the right brain. Contralateral. This nerve is also a purely sensory nerve. The oculomotor nerve deals with eye movement. It deals with moving the eye, opening the eyelid, constriction of the pupil, and focusing the eye. So it's going to adjust the pupil diameter, the size of the black hole in your eye, as well as the lens shape with focusing. These are all motor functions, so cranial nerve 3 is only a motor nerve. Damage to this nerve causes a drooping eyelid, dilated pupil, double vision, difficulty focusing, and inability to move the eye in certain directions. Cranial nerve 4 is the trochlear nerve. The trochlear nerve exits the brain through the superior orbital fissure and attaches to the superior oblique muscle. This means the trochlear nerve moves the superior oblique muscle. This makes it a purely motor nerve. Damage to this nerve causes double vision and the inability to rotate the eye inferiolaterally, so down and to the side. Our fifth cranial nerve, the trigeminal nerve, is a very large cranial nerve. It deals with sensation from the face, including touch, pain, and temperature, and runs the muscles of mastication, or the chewing muscles. So the trigeminal nerve innervates the temporalis muscle and the masseter muscle, as well as part of the digastric muscle. So this is an important muscle for chewing. This nerve has both sensory and motor input and output. Therefore, it is a mixed nerve, or does both sensory and motor functions. This nerve, as I said, is a large nerve, and it has many branches. It has a branch that goes to the mandible, one that goes to the maxilla, and then branches that go up to the upper half of the face. This nerve branches and goes through the foramen ovale, the foramen rotundum, and the superior orbital fissure. So 3 structures that we learned long ago when we looked at the skull. Cranial nerve 6, the abducens nerve, provides for eye movement. It specifically innervates the lateral rectus muscle, which moves the eye laterally. Therefore, damage to this nerve causes inability to rotate the eye laterally, and the eye will move medially at rest. This nerve is purely a motor nerve. The facial nerve has both motor and sensory functions. Therefore, it's classified as a mixed nerve, or it does both sensory and motor. The sensory functions it has are taste on the anterior 2/3 of the tongue. This portion of the tongue has a larger concentration of receptors for sugar and salt. Therefore, if this area is damaged, there's an impaired sense of taste, and often the senses of sweet and salty disappear. The motor functions of this nerve are facial expressions and all of the wet, gooey stuff that comes from your face. Salivary glands, tear glands, nasal glands, and palatine glands. All of these are innervated by the facial nerve. If we damage the facial nerve, we often get sagging facial muscles, as well as a disturbed sense of taste. There are 5 branches of the facial nerve, and they're named based on, for the most part, the bone that they cover. So the temporal branch is going to be the most superior branch. The zygomatic branch is below the eye, kind of runs along the zygomatic bone. The buccal branch runs along the cheek. So the cheek and mouth are the buccal cavity, therefore the buccal branch goes to the cheek and mouth. The mandibular branch goes to the mandible, and the cervical branch goes to the neck. The clinical tests for the facial nerve are to test the anterior 2/3 of the tongue with salt, sugar, vinegar, and quinine, which is a bitter taste. See what they can taste, if anything. They also can have their reflexes tested. So one reflex is the response of the tear glands to ammonia fumes. You should tear up and cry profusely if you are exposed to these. We can also test the motor functions of the facial nerve by asking the subject to close their eyes, smile, whistle, frown, and raise their eyebrows. If they can do these things, their facial nerve is probably not damaged. Number 8 is the vestibulocochlear nerve. Really long name, but it basically describes the 2 things that this nerve innervates. It connects to the cochlea as well as the vestibule. This nerve and the associated structures provide hearing and a sense of balance. Damage to this nerve can produce deafness, dizziness, nausea, loss of balance, and nystagmus, an involuntary rapid movement of the eyeballs. It looks like kind of a bouncing motion. The vestibulocochlear nerve receives sensation from both parts of the ear, therefore it is purely sensory. The glossopharyngeal nerve is number 9, and it comes out through the jugular foramen and deals with swallowing, salivation, gagging, control of blood pressure, and control of respiration. It also receives sensations from the posterior third of the tongue. Because the posterior third of the tongue has a higher concentration of taste buds for bitter and sour tastes, these tastes are impaired more dramatically if the glossopharyngeal nerve is damaged. The glossopharyngeal nerve is also a very important nerve in the first portion of swallowing, getting the food back into the throat and starting it on its way down the esophagus. The glossopharyngeal nerve deals with blood pressure because it is the nerve that receives signals from the sensors, the baroreceptors in the carotid artery. And based on that incoming information, the glossopharyngeal nerve may trigger another part of the brain to send out a signal to modify the rate and force of the heart. The vagus nerve deals with swallowing, speech, and regulation of the viscera or guts. Damage can cause hoarseness or loss of voice or impaired swallowing. If both of these nerves are cut, it is fatal. This nerve also exits through the jugular foramen, and it innervates not only structures in the neck, but also has a large branch that goes to the abdominal and thoracic cavity and innervates the heart, lungs, stomach, small intestines, kidneys, spleen, and liver. The vagus nerve is called the wandering nerve because it branches to so many different places, which is much like what you might do in Vegas, wander around. However, it is not spelled Vegas like the city. This nerve is both sensory and motor. Our 11th cranial nerve is sometimes called the spinal accessory nerve or simply the accessory nerve. This nerve comes out of the cervical spine, goes up, loops through the foramen magnum, and then loops back out through the jugular foramen and innervates the muscles of the shoulder and the neck. So damage causes impaired head, neck, and shoulder movement, and the head tends to turn towards the injured side. Our last cranial nerve is the hypoglossal nerve, and this goes to the tongue for movements for speech, food manipulation, and swallowing. If both are damaged, you cannot stick out your tongue. However, if one side is damaged, the tongue will stick out, but it deviates heavily towards the injured side due to ipsilateral atrophy. The hypoglossal nerve is purely a motor nerve. This wraps up our discussion of the cranial nerves and the brain and associated structures.